Information we have on this comes from studies done by Robert Muckerman in the 1960s in owl monkeys. But because we do pneumatic retinopexy, we've been able to study reattachment in vivo in humans as it's occurring. And we've devised a staging system for how the retina reattaches over time. So take this patient with a macula-off retinal detachment. Initially, you see some cystoid macular edema and corrugations. When we put the bubble in, there's a redistribution of fluid. In stage 2, look at the corrugations in the CME that go away. In stage 3, you get contact of the retina with the RPE. In stage 4, there's a detergescence of the photoreceptor layer. And in stage 5, you get recovery of the outer retinal bands from the ELM to the EZ to the interdigitation zone in a very predictable manner. So here's another animation video demonstrating this. So initially a baseline appearance, redistribution of fluid in stage 1. See the CME and corrugations go away in stage 2. This is very critical. In stage 3, there's contact of the retina with the RPE and then a detergescence of the photoreceptors in stage 4. You then get recovery from the ELM to the ellipsoid zone to the interdigitation zone, followed by the foveal bulge. Now, if you have a delayed recovery or progression through stage 2, you can get these outer retinal folds, and if you have a delay progression to stage 3, you can get residual subfoveal fluid blebs. Subfoveal fluid blebs can be beautifully seen with en-face OCT, and here you can see how the subretinal fluid gradually reabsorbs over time. This is a patient with an inferior dialysis who had a pneumatic retinopexy. Here you can see over time that the fluid is naturally reabsorbing over time by occluding the retina or tamponading the break. And you see this subfoveal fluid and subretinal fluid that gradually reabsorbs over time, just like puddles drying up in the sun. And you can see with this time-lapsed en-face OCT video how the fluid nicely resorbs. And sometimes it can take a long time, up to 6 to 9 months. But what we found is that visually, although it's initially lower when you have subfoveal fluid blebs, it always catches up, and it doesn't seem to compromise outcomes in the long run. Thank you very much, and I'd now like to introduce Wei Li, who's
on outer retinal folds, which is a microstructural abnormalities that can occur after an RD repair. I have no financial disclosures. In this talk, we are going to learn what is the best way to detect outer retinal folds, how does it impact our patient, understand the pathophysiology of outer retinal folds, and using that, find ways to reduce outer retinal folds. I'm going to start with the case that we see day to day in our retinal clinic, a patient with a macula-off retinal detachment. A month after RD repair, retina is attached, but patient's vision is 20/60. And when we take a look at the macula, there were no gross abnormalities seen. But as we take a closer look at the en-face and cross-sectional OCT scans, we found that there were presence of hyper-reflective curvilinear line, and this corresponded with the protrusion seen on the cross-sectional scans. So these are outer retinal folds. Outer retinal folds were first described by Benson et al. In 2006. Subsequently, Delamo and Peretti demonstrated that incidence of outer retinal folds were fairly high after vitrectomy, and that they were associated with worse functional outcome. So our group performed a post-hoc analysis of the pivot trial, looking at incidence of outer retinal folds after vitrectomy compared to pneumatic. And we found that incidence of outer retinal folds was significantly higher after vitrectomy at 34.1% compared to 14.3% after pneumatic. So what is the best way to detect an outer retinal folds? It is important to note that different segmentations of OCT results in varying outer retinal folds appearance. In the EZ segmentation, outer retinal folds appear as a wider hyporeflective lines, as representing the area devoid of EZ as EZ is folded to form the outer retinal folds. In the RPE segmentations, outer retinal folds appear as a fine hyporeflective line, representing the shadows of the outer retinal folds. But in our customized slab, outer retinal folds appear as a hyper-reflective line, and these prominent lines aids us in detecting the outer retinal folds. So our customized en-face slab extend from the junction of outer plexiform outer nuclear layer to the junction of myoid and ellipsoid zone. These are serial OCTs of 2 patients demonstrating resolution of outer retinal folds with time. Although outer retinal folds resolve with time, in this study, we learned that presence of outer retinal folds were associated with worse ETDRS letter score at 1 year. So the difference, patient with and without outer retinal folds were different by 9.4 ETDRS letters. And when we perform a sensitivity analysis on the vitrectomy group alone, the difference was 12.6 letters. So in order to understand the pathophysiology of outer retinal folds, we have to go back to histology study, where McCormick et al. First described outer retinal corrugations. Decades later, Delvin et al. Demonstrated similar findings on OCT and termed them hydration folds. Delamore et al. Was the first to describe that outer retinal folds originates from these outer retinal corrugations. So we learned earlier in the staging system that if there is insufficient time for the outer retinal corrugation to resolve in stage 2 before it touches the RPE in stage 3, this can lead to the formation of outer retinal folds. So in the vitrectomy, during air fluid exchange, fluid is actively drained from the subretinal space, and retina is reattached immediately. There is insufficient time for the outer retinal corrugation to resolve before it touches the RPE, leading to the formation of outer retinal folds. Comparing this to a pneumatic, where after a gas injection, patient is required to alter head position to position the bubble over the brake, and subretinal fluid is slowly reabsorbed by the RPE pump. These are serial OCTs of a patient after pneumatic. There is sufficient time for the outer retinal corrugation to resolve before it touches the RPE. Therefore, there are no outer retinal folds formation. So the take-home message is that outer retinal corrugation needs to resolve before retina is reattached. Therefore, a slower, more natural reattachment is better than a faster, forceful one. In order to reduce the incidence of outer retinal folds, we need to consider RPE pump-based procedures, for example, sclerobuckle or a pneumatic retinopexy, or even modification of surgical techniques to reduce the incidence of outer retinal folds to achieve a better functional outcome for a patient. Thank you.
Okay. So anomalous PVD can be associated with vitreoskisis, and vitreoskisis can result in some remnants of vitreous, of the cortex vitreous, very tightly attached to the retina. These cortex remnants can be found at the macula or at the periphery in about 70% of cases with the primary rhegmatogenous retinal detachment. These VCRs are very important because they have been associated to primary reattachment failure in a patient with a rhegmatogenous retinal detachment and also with the development of macular pucker. In this lecture, I would like to focus on the potential influence of VCR on retinal integrity, focusing on two main aspects, the unintentional retinal displacement and the formation of outer retinal folds. Regarding the retinal displacement, we thought that removal of peripheral VCR could impact on the displacement because removing the VCR, we can make the retina more mobile. Because as you can see from this video, the VCR are very strongly attached to the retina. So making the retina more mobile can signify reducing or promoting the displacement. But actually, putting together a lot of factors, we found that the only one that was significant to induce displacement was the use of gas. As previously noted in other publications and also reiterated by a recent mathematical and computer-based model by the group of Dr. Mooney. Regarding the influence of macular VCR on outer retinal folds, again, we thought that making the retina more elastic at the macula can have impact on the rate of post-op outer retinal folds. We know that outer retinal folds form in correspondence of outer retinal corrugations, and some surgical technique like vitrectomy can favor the formation of outer retinal folds because we force the retina to reattach using PFCL or high-tension products like gas. We also know that the stiffness of the attached retina regarding the inner and outer layers is different from the stiffness and the elasticity of the outer retina and inner retina when the retina is detached. And Dr. Mooney work team has taught us that there is a ratio between the elastic modulus of the inner retina and outer retina that it's very important to consider it when we study the outer retinal corrugations. So we thought that looking at the inner retina too could be important. And actually, we noticed that some preoperative biomarker on OCT can be very useful and highly specific to find then macular VCR intraoperatively, like this sawtooth aspect of the retinal surface. Another biomarker, biomarker on OCT that can be highly sensitive but poorly specific is the presence of this pre-retinal hyperreflective layer. So the question is, can the macular VCR increase the stiffness of the inner retina and play a role in outer retinal folds formation? I show you two cases. In the first one, there is a presence of outer retinal corrugation pre-op. There are no pre-op biomarker on OCT of macular VCR, and actually we didn't find macular VCR intra-op. This patient had PPV and tamponating with SF6 20%. We do not have any post-op outer retinal fold. In this case, we have both the sawtooth aspect of the inner retina, we have pre-retinal hyperreflective layer, and we have outer retinal corrugation. In this patient, we found macular VCR, but we didn't remove them. And after operation, we see the outer retinal folds and this corrugation of the inner retina. And also putting several factors together in a multivariable logistic regression analysis, we found that both the presence of macular VCRs and their removal were significantly associated with the presence of outer retinal folds. So in conclusion, peeling of peripheral VCR does not have an impact on retinal displacement, but might reduce the redetachment rate due to PVR, and peeling of macular VCR may reduce the occurrence of outer retinal folds. We don't know if this can reduce the post-op metamorphopsia or increase the post-op visual acuity. Thank you.
Thank you for the introduction, and thank you for the opportunity to speak here. My name is Natalia Figueiredo. I'm going to talk about assessing post-operative photoreceptor recovery with unfast OCT. I have no financial disclosures. I'm going to start with a real case. A patient comes to your office presenting with a successful anatomic reattachment after a macula of Rhegmatogenous retinal detachment. The retina looks great and it's fully attached, but the functional outcomes, including visual acuity, they are reduced and the patient is unhappy. So let's look deeper. We can, looking deeper to the cross-sectional B-scan OCT, we can see that the EZ shows abnormalities, but it is hard to get a sense as how extensive it is. We decided to explore the photoreceptor recovery with unfast imaging, and analyzing the unfast image of the ellipsoid zone slab, we could observe an extensive hyperreflective region. Then, we wanted to explore this formally, so we did a post-hoc analysis of the pivot trial. We used the default ISOS automated segmentation from the Zeiss software. Here's an example of this segmentation, and its unfast image to the right. The aim of the study was to quantitatively assess EZ recovery using unfast OCT and to determine the correlation between EZ recovery and visual acuity improvement. We analyzed unfast images of the ellipsoid zone slab, and the hyperreflective regions, they were assessed quantitatively. Over the 181 images analyzed, a statistically significant reduction was observed in the mean area of hyperreflective over time from 3 to 24 months. And as the measured area of EZ hyperreflectivity significantly declined, the ETDRS letter score improved. To sum up, EZ recovery can be quantitatively documented after Rhegmatogenous retinal detachment surgery using unfast OCT images. A steady reduction in the area of abnormal ellipsoid zone was observed over time and correlated with visual acuity improvement. And hyperreflective areas on unfast OCT may serve as a useful biomarker for EZ integrity. So going back to the patient that we showed in the beginning of the presentation, we can see a gradual reduction over 2 years time from 3 to 24 months. And as the measured to 24 months significant reduction, they were assessed quantitatively. Over the 181 images analyzed, a statistically significant reduction was observed in the mean area of hyperreflective over time from 3 to 24 months. And as the measured area of EZ hyperreflectivity significantly declined, the ETDRS letter score improved. To sum up, EZ recovery can be quantitatively documented after Rhegmatogenous retinal detachment surgery using unfast OCT images. A steady reduction in the area of abnormal ellipsoid zone was observed over time and correlated with visual acuity improvement. And hyperreflective areas on unfast OCT may serve as a useful biomarker for EZ integrity. So going back to the patient that we showed in the beginning of the presentation, we can see a gradual reduction over 2 years in the hyperreflective region. However, we still find it at 24 months. And in the study, the long-term follow-up assessment identified a significant reduction of the hyperreflective area over a period of at least 4 years, as shown in this image. The unfast OCT scan has also the advantage of demonstrating the entire area of EZ hyperreflectivity in a single image, and it can be reassuring for the patient to see the recovery over time. Finally, the longer the duration of macula off detachment, the less the improvement was found in EZ hyperreflective areas. To conclude, EZ hyperreflective area on unfast OCT represents a quantitative assessment of photoreceptor integrity. This imaging biomarker is correlated with long-term visual acuity outcomes. The duration of macula off detachment impacts the speed of photoreceptor recovery, and photoreceptor recovery can continue over a period of at least 4 years and likely longer. Thank you.